Now we'll talk about sleep issues in patients with dementia. Alzheimer's disease is the prototype dementia, and it is also the most common cause of irreversible dementia in adults. Alzheimer's disease is a neurodegenerative disorder and causes progressive decline in memory and cognition. Pathology is mainly related to aggregation of amyloid and phosphorylated taus. Tau pathology correlates more with neuronal dysfunction. The areas involved are the entorhinal cortex and the limbic system and the neocortex. Newer evidence suggests that early involvement may be in the locus coeruleus and other sleep-wake regulatory nuclei. Histopathology is associated with, I'm repeating the last line again. Histopathologically, we can find neuritic plaques, tangles, and neuronal loss is seen. Sleep problems worsen functional status and can be a major reason for institutionalization. Obstructive sleep apnea is more common in Alzheimer's disease. Why? If epsilon 4 gene increases a risk for both OSA and Alzheimer's disease. REM sleep behavioral disorder is however rare in Alzheimer's disease because it is not a synucleopathy. Sundowning can be seen in Alzheimer's disease. It is delirium-like, more in the evening or nighttime situation where confusion, agitation and aggression can occur, and sometimes wandering can be there. This is partly due to dysfunction in suprachiasmatic nucleus. In Alzheimer's disease, the main sleep changes are altered circadian markers, that is shifting of core body temperature and melatonin rhythms. Melatonin production also is reduced even in preclinical AD. Early degeneration of nucleus basalis majornis also affects the suprachiasmatic nucleus modulation and cortical arousal control. The EEG changes in sleep and sleep architectural changes in Alzheimer's disease, mainly arousals are increased and it is frequent and prolonged, and this leads to fragmented and non-restorative sleep. And there is an increased percentage of N1 sleep when compared to control, which causes a light sleep, and in N3, that is a slow wave sleep, that is a reduced compared to controls, and this leads to impaired memory consolidation and decreased clearance of amyloid. REM sleep is also decreased, which is mainly shortened and delayed in comparison to controls, and cognitive and mood dysregulation is seen due to the same. As disease progresses, the total architecture is worsens, and which correlates with the severity of neurodegeneration. EEG findings are an awake EEG in Alzheimer's patients. The dominant occipital rhythm is slowed and is pushed towards theta and delta activity, which reflects cortical slowing, and also it is seen in neurodegenerative diseases. Variable correlation with severe disease severity. However, it is not a consistent reliable severity marker. I'll repeat it again from the start. Various EEG findings in Alzheimer's disease are noted. Mainly in awake EEG, the posterior dominant occipital rhythm is overall slowed, and the alpha rhythm is slowly changed towards theta and delta activity as disease progresses. However, this is not a direct correlator of disease severity, and it can be seen in other common neurodegenerative disorders also. REM sleep EEG, more prominent slowing than in wakefulness. Regional slowing is seen in temporoparietal regions and frontal regions. In non-REM sleep, there are fewer and lower amplitude K complexes, and it indicates physiological slow wave degeneration. How do we treat insomnia and dementia? There are, apart from your sleep hygiene and cutting down of evening fluids and caffeine, we can consider medications when these efforts fail or do not fully satisfy the patient. Can be tried on trazodone, chloraldehyde, melatonin, or when psychosis and hallucinations also predominate, we can try zolpidem and quetiapine or suvorexant. In predominant psychosis, behavior control and agitation and wandering can be helped by augmenting choline transmission in the forebrain. Mainly this can be done with donepezil, rivastigmine and galantamine. You can see the doses, which can be slowly has to be titrated every month. And risperidone, olanzapine, clozapine, quetiapine can all help with agitation and wandering. Sometimes behavioral discontrol can be handled with valproic acid and carbamazepine also. Excessive daytime somnolence can be treated with methylphenidate, can be treated with modafinil, armodafinil, or a combination of amphetamine and dextromethorphan. I'll say the last line again. Can be treated with amphetamine or dextroamphetamine combination as well. As you can see, these doses are to be carefully titrated, and we can see the maximum doses in this column. When coexistent restless syndrome and RBD are present, one may resort to treatment with pramipexole. However, has to be taken care regarding augmentation when coexistent Parkinson's medications exist. Gabapentin is the drug of choice, currently FDA approved. Secondly, with pregabalin, we can see the actual doses is what we start is very less, 25 to 15 pregabalin and gabapentin 100, but we have to reach around 300 to 1800 milligram in the night and 100 to 600 milligram pregabalin in the night. And when RBD is present, clonazepam and melatonin can also be tried. Coming to neuromuscular disorders, these disorders also affect sleep very significantly. Neuromuscular disorders are the disorders of motor unit, which generally involves the lower motor neuron, the nerve root, the peripheral nerve, the neuromuscular junction, and the muscle. The pathophysiology of sleep dysfunction in neuromuscular disorders revolve around the diaphragm, which is the primary muscle of respiration during wakefulness and sleep. What happens in NREM sleep, non-REM sleep is there is already decrease in ventilation due to reduced chemosensitivity and increased respiratory impedance. However, diaphragmatic and ribcage activity is preserved to a bit. And during REM sleep, there is a motor atonia of the accessory muscles and the intercostal muscles, and diaphragm becomes the only relatively sole preserved muscle for respiration. So, any diaphragmatic muscle weakness in a patient with already, I'll repeat it again. So, any diaphragmatic muscle weakness will cause severe hypoventilation, and bilateral diaphragmatic paralysis can cause profound desaturations in REM sleep. There is a vicious cycle of weak respiratory muscles. Muscle weakness will cause decreased tidal volumes, it will cause microatelectasis, it will cause decreased compliance, hence there is a decreased ventilatory perfusion mismatch and worsening of hypoventilation. There is the various disorders described in neuromuscular disorders based on the primary disease. It can be due to central apnea, due to primary pump failure, mainly the muscles of the respiration. It can be due to obstructive sleep apneas. It can be due to nasal airflow limitation. It can be due to prolonged hypoventilation, and many of the times they have mixed patterns. And common contributions to these diseases are weakness, pain, spasms, retained secretions, abnormal postures, and positional discomfort. And all of these lead to hypoventilation at the end, and these causes arousals and sleep fragmentation and daytime sleepiness. Over time, there is a blunted ventilatory response to CO2, and hypoventilation also extends into wakefulness. Commonly in most of the neuromuscular diseases, there is fatigue, hypersomnolence, and sleep fragmentation, often the earliest signs. There is drooling, aspiration, and infections due to decreased airway clearance. There can be retained secretions due to weak cough, autonomic dysfunction, mainly temperature and pressure sensitivity can be there. There can be pain, anxiety and depression, and insomnia can be a common cause of this. And medications, mainly stimulants, the evening stimulants or the AM sedatives can also worsen the sleep-wake disruption. I'll say the last line again. Medications such as morning sedatives and evening stimulants can worsen sleep-wake disruption. In neuromuscular diseases, nocturnal hypoventilation is quite common, and this can lead to early morning sleepiness and morning headache. The main pathophysiological reason is diaphragmatic weakness. In sleep apnea, or mainly obstructive type, even it is associated with snoring and arousals. It is due to upper airway collapse due to muscle weakness itself. The sleep efficiency itself is decreased due to fragmented sleep, due to muscle weakness and discomfort. And the REM sleep is also decreased, as we previously talked about. And hypoventilation worsens. This is due to loss of intercostal muscle support. And diagnostic tools for NMD and sleep disorders are mainly polysomnography and capnography, which confirms the nocturnal respiratory failure. Coming to specific subtypes of neuromuscular diseases, we'll talk about amyotrophic lateral sclerosis, poliomyelitis, secondary neuromuscular disease due to traumatic spinal cord injury, Charcot-Marie disease, myasthenia gravis, and pure muscular dystrophy such as myotonic dystrophy and Duchenne muscular dystrophy. In ALS, sleep disorder breathing is close to around 17 to 76%, and sleep disruption mainly comes from cramps, pain and choking sensations and immobility. REM hypoventilation happens due to, I'll repeat it again. In amyotrophic lateral sclerosis, the prevalence of sleep disorder breathing is around 17 to 76%, mainly due to sleep associated cramps, choking due to secretions, fasciculations and immobility, and due to orthopnea. REM hypoventilation happens due to phrenic motor nerve damage, and sleep disorder breathing may occur even with normal daytime respiratory tests. In poliomyelitis or a post-polio syndrome, there is a decreased efficiency and increased arousal and prolonged REM latency. In poliomyelitis or a post-polio syndrome, around 30% of the patients may have sleep disorder breathing, mainly of central or mixed or obstructive apnea due to craniofacial abnormalities, chest wall deformities and restrictive physiology. There is an associated decreased sleep efficiency, increased arousals, and apnea or hypopnea and prolonged REM latency. In traumatic spinal cord injury, there is highly variable, mainly related to the site of the lesion. If it is in the high cervical cord, there is a high chance of sleep disordered breathing. Sleep worsens between 2 to 12 weeks post injury and increases nighttime mortality. And cervical lesions cause diaphragmatic or intercostal weakness, can cause impaired cough. I'll repeat from the middle. Cervical lesions cause diaphragmatic or intercostal weakness or impaired cough, J reflux. Sympathetic pathways are also disrupted, and there is impaired melatonin secretion. In peripheral neuropathy, mainly congenital or familial, in Charcot-Marie tooth disease, which is a hereditary motor neuropathy, although the sleep disordered breathing prevalence is not quantified, they have coexistent pharyngeal neuropathy or upper airway resistance syndrome, or this which can contribute to pharyngeal weakness, or an autonomic neuropathy with blunted CO2 sensitivity and upper airway obstruction, and sleep fragmentation can happen. In myasthenia gravis, sleep disorder breathing can occur around 60% of the patients, and OSA can be seen around 36%. It is due to pharyngeal or diaphragmatic weakness, and the risks of these increase with age and BMI, or a coexistent restrictive lung disease and CO2 retention. They may be having REM-related hypoventilation and apnea, hypopnea also. Coming to specific muscle diseases, in myotonic dystrophy, daytime sleepiness is seen in around 30 to 70% of the children, and it is due to CNS dysfunction. It is due to central hypersomnia, and problem is with the respiratory control abnormalities, and additionally muscle weakness and craniofacial abnormalities also puts them with OSA risk. So there is both REM hypoventilation, central and obstructive hypnea, and there is a short sleep latency is also noticed in myotonic dystrophy patients. In Duchenne muscular dystrophy, it is very common and it is age dependent. Younger people with Duchenne muscular dystrophy have OSA, older people will have REM and non-REM hypoventilation. They often need NIV, and glucocorticoids may be helpful in improving the restrictive lung disease, but may worsen the central obesity and may again worsen the REM hypoventilation. So management is common, mainly early detection of sleep disorders and neuromuscular diseases should be attempted, and nocturnal and daytime hypoventilation has to be characterized through polysomnography and oximetry, and then we have to tailor the treatment accordingly. Mainly in NIV, non-invasive ventilation improves sleep architecture and daytime alertness, ventilation and quality of life. Apart from that, we have to do general measures such as optimizing bed positioning or pain management in neuromuscular disorders. Cautious use of sedatives has to be advised. As we discussed, polysomnography can guide the treatment in certain neuromuscular diseases, mainly in DMD, such as Duchenne muscular dystrophy. For REM related desaturation, supplemental oxygen may be helpful. However, this does not improve sleep, but it improves cardiac morbidity, and sometimes this can improve muscle weakness or at least maintain it. I will repeat the slide again. In Duchenne muscular dystrophy, treatment can be, some part of the treatment can be guided by polysomnography. REM related desaturations can be picked up and oxygen therapy can be administered. Although this does not improve the sleep, it improves or stabilizes muscle weakness. Another example in such a scenario is acid maltase deficiency, where nocturnal oxygen has stabilized muscle weakness over 8 years in one report. Apart from nocturnal oxygen, there is a need for inspiratory muscle training, which can improve daytime respiratory function and nocturnal oxygen saturation. Some patients with acid maltase deficiency, Duchenne and other spinal muscular atrophy people also are beneficial with inspiratory muscle training. Wake promoting medications are also important in patients with neuromuscular disorders, mainly modafinil and armodafinil. They improve daytime alertness and fatigue, particularly in ALS and multiple sclerosis and Duchenne muscular dystrophy. They do not significantly disrupt nocturnal sleep. A pharmacological suppression of REM sleep is an exciting area, but it has its own limitations, simply because most of the ventilatory abnormalities or hypoventilation occurring in REM, it is tempting to reduce the REM. I'll repeat it from the middle again. Pharmacological suppression of REM sleep is an exciting area to try, simply because the most hypoventilation and the pathogenesis is revolving around REM desaturation. One is easy. I'll repeat it again. Pharmacological suppression of REM sleep is an exciting area because the REM hypoventilation is the main culprit, and if we could decrease the REM by pharmacological means, it would be helpful. Example is the tricyclic antidepressant nortriptyline or protriptyline. However, these medications will have anticholinergic side effects and have to be carefully evaluated. Spasm and spasm, pain and sedating medications I'll repeat it from the middle. Spasm, pain and sedating medications are important in controlling the pain and mobility, but also have to be very careful because of the sedative effects and the risk of hypoventilation, example with opioids, and maybe excessive daytime sleepiness due to baclofen. Particular pediatric considerations are the DMD and spinal muscular atrophy, which both can progress to nocturnal hypoventilation and later to daytime hypoventilation. Timing of intervention is very crucial. Mainly it helps in airway clearance, and also NIV has to be instituted when appropriate. When early NIV is given, it promotes proper lung and chest wall growth during development. Myofunctional therapy is an exciting rehabilitative tool wherein orofacial weakness which occurs during development are caught early by evaluation and a myofunctional re-education. I'll repeat the last part again. Myofunctional therapy is an evolving tool to develop in rehabilitation of these diseases, wherein orofacial weakness which happens early in the development, which causes reduced orofacial growth and also airway narrowing, is addressed by re-education of the muscles involving swallowing or speaking or nasal breathing. This way, by giving functional exercises and retraining or re-educating the muscles around the face and the neck, one can expect to improve airway patency. We have come to the last section of the talk. There are many autoimmune disorders which have significant effect in I'll repeat it again. Coming to the last section of the talk, there are many autoimmune disorders which have significant effect on sleep, such as LG1 autoimmune encephalitis, anti-MAT2 encephalitis, NMD encephalitis. However, these are extensively covered elsewhere. We talk about a new novel autoimmune disorder which has been recently characterized in 2015, and more data has been coming up. So we will talk about that disease. This disease is anti-Glon 5 disease. The etiology is generally considered immunological and not paraneoplastic. It is associated with antibodies against Eglon 5, a neuronal cell adhesion protein. It has a strong HLA predisposition to 60 to 80% with DRB1 and DQB1 genes. The neuropathology is now considered as a novel neuronal tauopathy, wherein tau deposits and neuronal loss occurs in the brainstem tegmentum and hypothalamus. The epidemiology, as we can see, the age of onset is around 50 to 70 years, and it is insidious on onset and slowly progressive. And mortality is up to 60% due to sudden stridor or the mortality, I'll repeat it again, the last line, mortality is up to 60%, often due to sudden death during sleep or wakefulness. The key clinical features is the staring one is the prominent sleep disorder up to 90% of the patients, wherein people have abnormal sleep-related vocalizations, complex behaviors, loud respiratory noise, stridors or apnea, and mild to moderate excessive daytime sleepiness. The main clinical features of this disease comprise of a prominent sleep disorder which is manifested by abnormal sleep-related vocalizations, movements, complex behaviors, sometimes loud respiratory noises, stridor, apneas during sleep. Excessive daytime sleepiness is, however, very mild, and circadian rhythm is actually preserved, and the total sleep time is remarkably only mildly affected. There is a prominent bulbar dysfunction associated with vocal cord palsy, dysarthria and respiratory failure. There can be gait and motor disorders with chorea being less common, and peripheral hyperexcitability with stiffness, spasms, cramps and fasciculations can also be seen. Other neurological dysfunctions associated with Eglon 5 diseases are oculomotor eye abnormalities and dysautonomia. MRI and CSF are typically normal in this disease, and polysomnography is very helpful in finding complex parasomnia involving both non-REM and REM period. Obstructive sleep apneas can also be picked up and it can be apparent throughout the sleep. Stridor is frequently present during normal non-REM phases also. During REM sleep, there is loss of muscle atonia and frequent limb and body jerks also is seen. The NREM sleep abnormalities in Iglon 5 disease is there is a particularly undifferentiated NREM sleep and there is diffuse irregular theta activity, absent vertex waves or absent K complex of spindles, poorly formed N2. There is sparse but present K complexes and speech. I'll repeat it again. There is poorly structured N2. There is a sparse but present K complex and sleep spindles. Associated behavior such as vocalizations, murmuring, whispering, groaning, grasping, or purposive like behaviors can be present. Eating movements or manipulating objects can also be seen. Behavioral context occurs only during sleep and never during wakefulness, not associated with dream, mentation or hallucination. During sleep progression, if uninterrupted, NREM gradually normalizes to N2 to N3 with normal spindles, K complex or delta. Here we can see a patient with Iglon 5 disease wherein there is a generalized slowing. The high activity is going into theta range and delta range and followed by muscle artifacts due to movements in the mentalis, chin, and also due to legs. So this NREM staging, the transition is correlating with the abnormal movement also with the chin and the lower limb muscles. The treatment of Iglon 5 disease still is not very satisfactory. The treatment is with high dose IVIG, steroids and maintenance rituximab. However, the treatment response is not very satisfactory, particularly the sleep dysfunction does not respond well with the treatment. Mild cognitive dysfunction and oculomotor abnormalities may improve with the treatment. So with this, I conclude briefly various neurological disorders which have effects on sleep and sleep affecting neurological disorders. Thanks a lot for everyone for giving me this opportunity. Thank you.